I'm going to talk about the basics, which all the residents and we all should know about. And then I'm going to move into some recent data on upper tract urothelial cancer incidence and survival. And I'm really going to use that information as a way to guide us into what are the issues in management that we need to focus on. And then the last part is a review of some recent articles on meta-analysis articles on neoadjuvant adjuvant therapy, because I think that's really the focus that we have to take with treatment of this disease. So let's begin. Let's see if I can, come on. Good. So diagnosis, upper tract urothelial cancer patients often are asymptomatic with only microscopic hematuria. But when we find in localized disease, there could be a microscopic or gross hematuria, dysuria, flank pain. In advanced disease is more characterized by flank or abdominal masses, weight loss, anorexia, bone pain, because they could be in advanced disease and have these issues. Routine laboratory evaluation, of course, is no renal function, urinalysis, culture, cytology, and cystoscopies always should be performed. It's your routine diagnosis for hematuria is what we're doing first. If you suspect this, a CT urogram with and without contrast and cystoscopy. But really the key approach for diagnosis is flexible ureteroscopy with retrogrades and biopsy. And I've said this in the past when I was, in my earlier experience, it was difficult to find upper tract disease because, using at that time IVPs coming out of training and everything. But now with the technology, we have a better opportunity to find it and diagnosis. But we do have problems, you'll see later, with staging. So when possible, biopsies and selective cytology should be achieved. And you can use a access sheath. The biopsies that we're performing are really small, 1 to 2 millimeters backloaded. It helps with obtaining these biopsies. But you're really trying to obtain tissue sampling for grade and histology. Stage is going to be difficult because we can't do deep biopsies. And what I tend to do also, if at all possible, we have the ability to take photographs during ureteroscopy, so I use those. Cytologies is, urine collection or washings of the ureter with a ureteral catheter provides really accurate cytology results. You have to always make sure you don't have contamination from other sources, so make it as clean as possible. Selective washings, in addition to the biopsy, can serve as for prognosis. If a positive cytology with a negative cystoscopy, it's possible that you have upper tract UC or prostatic ureteral cancer. In the absence of a solid tumor, a positive selective cytology suggests that you may have CIS in the bladder. And here's a nice diagram out of Campbell's, which really demonstrates that for you. So if you have a positive cytology in the upper tract imaging, if it's negative, then cystoscopy with bladder biopsy. So if it's not in the upper tracts, it's in the bladder. If it's positive, it's probably a cancer, CIS, and that goes to obtaining BCG. Yeah, obtaining BCG. This is a lower right. If it's positive, then you're looking to extravesical evaluations, prostatic urethral biopsies, or the upper tract. So it's either upper tract or lower tract. Imaging is really important, cross-sectional imaging. This is where we've been using MRI so frequently, but really CT urogram has the highest diagnostic accuracy. but MRIs are used for inadequate renal function, contrast allergies. A chest CT should be obtained in these high-risk patients because they have metastatic disease. Prior to removing a kidney, a radical nephroureterectomy, make sure you look at differential function. I mean, these are examples of CT urograms that we have. Looking at figure A, to see really the difference that you have to look at. Sometimes in the larger masses, you don't know, but see a renal cell is going to come out from the parenchyma, where these are going to come out centrally. And I recall this as a medical student opening up a kidney. This in pathology. I love pathology, and you can see this urothelial cancer was like kind of, growing a big flower out of the renal pelvis. So these are always centrally located. And so you're really looking for filling defects, whether in a CT or with a retrograde studies. So this is all part of your guidelines. This is for NCCN guidelines to follow. For renal pelvis, everything we just talked about is on the left side of the screen. And you're really differentiating non-metastatic to metastatic. And then the biopsies are going to help you with whether it's a low grade or high grade, but you'll see that high grade is really more prevalent. And then we'll talk about therapy. For the ureter, same workup evaluation, but then this is an upper, mid, low grade, high grade, and distal. And really the differences here, we discussed this at last tumor conference. Upper, mid is really, you have to really go with the nephroureterectomy, whether it's high or low grade, and endoscopic resection only if it's really discrete. But the guidelines do give the opportunity in distal tumors for a distal ureterectomy with lymphadenectomy, in addition to a nephroureterectomy with the cuff. So, and we're going to discuss this quite a bit. And then later on, we're going to talk about the systemic therapy. The challenges with upper tract UC, as I mentioned before, is just that we don't have very good staging. It's really incomplete and inaccurate grading and staging of the cancers. And that's what better improved imaging studies or something needs to help us with that, because we don't know what we're dealing with up front prior to our treatment all the time. And so also we're limited by the size and available endoscopic and biopsy equipment. And this is where I think in the future, maybe with genetic studies, biopsies, a little biopsy may not give you the pathology, but the little biopsy may give you the genetics of the tumor. And that's, I truly believe that that can help us guide and the genetics can be a prognostic factor that's going to help us with management. Cross-sectional imaging, as I said, does not accurately stage invasive disease. So this is our, the TNM classification that you should be familiar with, and it really mimics the bladder staging. A diagram that's showing this, the T3 going into fat, T2 into muscle, T1 laminar propria on the surface. You're all familiar with this. The one thing is, it's like a waterfall effect. These you're going to see there's more tumors distally. So if they come up here, they're seeding, and they're really seeding the entire ureter, and then it's going to seed the bladder also. And so you have to be careful of manipulating the upper tract that you're going to seed your bladder also. And you're also going to see in other discussion that here in the bladder on the trigon, if they have like a CIS or papillary near the UO, it can go up the distal ureter, really kind of promotes distal ureteral tumors. Risk factors. Smoking, of course, is number one. A bladder cancer. Questions? Bladder cancer promotes upper tract disease. Lynch syndrome, actually, you could spend a grand rounds talking about Lynch syndrome. As I said, we're just going to mention the astroloic acid from the Balkan Chinese nephropathy, arsenic, analgesics, occupational, chronic inflammation, and chemotherapy also. Bladder cancer is a risk factor for upper tract urothelial disease. And in bladder cancer patients, that risk ranges from 1 to 7%. And it seems that the higher risk of upper tract disease, this is important, comes from the low grade non-muscle invasive bladder cancers. And it's probably because it's just these people have such, because of its low grade, really prolonged risk. So many years they're being followed. And so, but that's what promotes a longer probability of having cancer, then gives them a longer probability of the developing upper tract disease. But in bladder cancer, you have to be careful of multifocality, carcinoma in situ, the proximity to the ureteral orifice. All those are warning signs that you may have to be more mindful of upper tract disease. Double J stenting during a TURBT, you want to maintain that renal function, but at the same time, you could be with reflux, seeding your upper tracts too. So it's a potential risk factor for future upper tract disease. Lynch syndrome is an interesting syndrome. It's hereditary non-polyposis colon cancer. It's the most common inherited cancer syndrome associated with colon, small bowel, endometrial, and ovarian malignancies. And 10 to 20% of these patients develop upper tract disease. The upper tract is the third most common cancer seen in this syndrome. And because of that, this is a whole screening. Again, I'm just briefly presenting this, but it could be a longer talk with this. But if you're looking at somebody who's has these characteristics, younger, history of colon cancer, first degree relatives with colon cancer, there's a germline DNA sequencing and see whether there's a mutation there. So this is already part of a genetic syndrome you must consider. Otherwise, the 80–90% have sporadic upper tract UC. This is a mutagen found in Eastern Asian herbal remedies, which promotes this in the Balkan nephropathy, Chinese herbal nephropathy. This just may pop up on your in-service. Let's go to natural history. Upper tract UC comprises only 5 to 10% of urothelial cancers. Majority of urothelial cancers rise from the bladder. And as I mentioned earlier, you'll find more ureteral tumors distally, 70%, 25% mid-ureteral, and 5% upper. And there's this downstream implantation of the cancer cells. You can get it at the same time, bilaterally, up to 6%. Adjusting for stage, ureteral and mid-focal, ureteral and multifocal disease have a worse prognosis than the renal pelvis. And this just makes those points again. So more about natural history. Thank you, excuse me. Cancer-specific outcomes matched cohorts from multi-center studies by Cato show that there's a similar frequency between the upper and lower tract UC. And I put a little star there because we're going to speak about that later. Prognosis for recurrence is related to the location of the tumor and the stage. Comparison of upper tract UC with radical versus the main point here is that upper tract UC has a worse prognosis in comparison to bladder cancer. We can treat bladder cancer in that stage and be curative, where upper tract may not will spread faster. Upper tract bladder cancer patients have a worse prognosis with non-muscle invasive bladder cancer. And the explanation for this is that with non-muscle invasive bladder cancer has these high-grade features like CIS, which are treated with TURBT and intravesical therapy. And so bladder cancer can harbor this aggressive disease unknowingly. And for that reason, there's a greater potential for developing upper tract carcinoma. Whereas if we have a more aggressive bladder cancer, they can be treated up front with this radical cystectomy. So the point is that you have to be careful with, again, the unknowns of bladder cancer. And the unknowns of bladder cancer can promote upper tract urothelial cancer. Upper tract disease after bladder cancer. So this, so after treating for bladder cancer, you have to be mindful of other symptoms, hematuria and flank pain. So primary detection with the cytology and upper tract imaging is really important. And metastatic disease can be found 18 to 33% of the time. So you have to really be mindful of people with bladder cancer, even of people after a radical cystectomy. Risk factors for upper tract reoccurrence includes the presence of distal ureteral tumors, multifocal recurrent UC, non-muscle invasive bladder cancer, and CAS. This is brought out in this paper. And the recurrence time, so you have to be mindful of this, can be more than 3 years. So when you're following a bladder cancer patient, you have to always be thinking about the upper tracts. And these risk factors are really important. And so you can see the difference. If there's no risk factors at 15 years, it's very low. But you have any of these risk factors in this list, the upper tract risk goes up by 10 times. That's a 13%. Upper tract reoccurrence will likely occur in T1 bladder cancers rather than TA, high grade. And the upper tract location is usually in the distal ureter, but it's fortunately in a TA, something a more controllable disease. So this is part of the EAU guidelines, and it really demonstrates all the things you need to think about, the prognostic factors for upper tract UC preoperatively and postoperatively. And this is what we talked about, the multifocality grade, their age, consumption, ECOG status, hydronephrosis. So you have hydronephrosis, you know that tumor has been there for a long time to cause that hydronephrosis, so likely it's going to have a higher stage. It's just like in bladder cancer, you should not delay surgery but move forward with this, and because 3 months is still kind of a critical. And tumor location, obesity, and this neutrophil lymphocyte ratio, if that's present abnormal, that could be a prognostic factor. And then postoperatively, you're looking at if you're managing the distal ureter, lymphovascular invasion. We're going to talk about the lymph node involvement and variant histology, all this postoperatively, as when we're talking about adjuvant therapy, adjuvant chemotherapy. So you can really categorize these two into low or high risk. And it's really kind of like in renal cell cancer, talking about nephron sparing surgery. Still, there's been a push to really kidney sparing management also. And rather than moving towards a radical nephroureterectomy, maybe trying to spare that kidney. And that's what I'm going to discuss later. So now in the guidelines, we've moved to primary therapy now for renal pelvis. And non-metastatic, high grade, it's the only way to manage these is the nephroureterectomy. And but now we're going to consider neoadjuvant therapy. With metastatic disease, it's going to be systemic therapy, as you'll see. If we're talking about upper tract urothelial cancer in different locations, the the most important point is nephroureterectomy with a cuff and adenopathy, excuse me, and lymphadenectomy should be performed, but distally we may be able to spare that kidney and do a distal ureterectomy. Adjuvant therapy, we're going to discuss whether for the low stage, not performing it, but we should consider this with adjuvant chemotherapy in the higher stage. That's what we're going to discuss. You're going to see that the T3, T4, and positive or negative are the stage, the patients that we need to consider most. And with or without radiation therapy, forget that. You know how I feel about radiation therapy. So treatment options, organ sparing approaches may decrease the risk of chronic kidney disease. And see, by sparing that kidney, a theme that I really want to bring out in this talk is that you have more advantages for chemotherapy and rather than taking the kidney. I think we need to focus on that to try to spare the kidneys more. So when possible, use ureteroscopy, laser ablation. They mentioned in Campbell's percutaneous resection, though I never have done that. I don't know if anyone else has done that. I just think that's just a higher probability of seeding. Segmental resection, reimplantation, using use of mitomycin C, though, you know, any of this kind of mitomycin therapy, trying to put that therapy in the upper tracts, I think is challenging. Radical nephroureterectomy with that lymphadenectomy, that should always be performed together. So let's talk about segmental ureterectomy. It's best suited for small focal tumors not amenable to ureteroscopic management. If you can't really remove that cleanly, then this would be an option. And distal ureterectomy tumors can be managed with a distal ureterectomy and then a formal bladder cuff and a reimplantation. And we've actually had we talked about 6 cystectomies. We've had a lot of distal ureterectomies with psoas hitches, and I tend to use the psoas hitch. Boari flap is one of Dr. Costa's favorite procedures. I think that guy can do that in 15 minutes. He can whip those out. So if you ever see him do that, that's something to see. Also, a lymphadenectomy should be performed. So just to explain this, it's psoas hitch means putting the bladder up to the psoas muscle, and then taking the top of the bladder and extending that. This is the Boari flap that Dr. Costa does so beautifully. And so I don't know how high, Joe, you have ever gone with this. Have you ever gone all the way up to the renal pelvis with one of these? Joe?
I have, but that was with a very unique, yes, I have, Mark, with a very unique bladder. The guy was in retention chronically and he could hold 3 liters capacity. So with the right bladder, you can reach up to the renal pelvis or kidney, but not very frequently.
Yeah, but you do these really frequently, very well. So that's how that looks. And then for a lymph node dissection, so any kind of distal tumor really should do your pelvic, your standard pelvic lymph node dissection, and the mid-ureteral and tumor pelvis. I really think that should be part of a nephroureterectomy or any surgery on the ureter. All right, so segmental ureterectomy. This was a systematic review and meta-analysis on the comparative studies of this. This was like recently published 2020. It did a systematic review, meta-analysis, 18 studies, 17 retrospective, multi-center, and single-center studies. There was no significant difference in the 5-year relapse-free survival or cancer-specific survival between the 2 groups. And if you look at this forest plot, you can see how it's swaying towards the segmental ureterectomy rather than the radical nephroureterectomy. So this would be something I think to consider when you're managing distal tumors. In addition to the no significant difference in 5-year relapse-free survival and cancer-specific survival, the segmental ureterectomy group had a lower rate of higher stage. So this is more lower stage tumors in this study. But they had higher grade tumors were more significant. It was associated with the history of bladder cancer, and these ureters, which were operated on in segmental ureterectomy, were less likely to have hydronephrosis. See, again, I think an interesting part of this, if you see hydronephrosis with a tumor, it means it's been there for a long time. It's not like a stone which is momentarily passing through. If you see hydronephrosis and you have a tumor, I think that is really a prognostic indicator of a higher stage, because this has a longer opportunity to grow and cause the hydronephrosis. So conclusion for this study, this meta-analysis, that you should consider segmental ureterectomy as a treatment option for selected distal UTUC patients. And this offers a preservation of renal function. But of course, you have to have strict upper tract follow-up is really mandatory. But if you know of someone already with advanced high-risk disease, the radical nephroureterectomy and lymph node dissection is standard of care. Just briefly about this, I'm just passing through this to be complete. It's when you're doing a radical nephroureterectomy, it's important to clip that ureter early. Bladder cuff can be taken extravesically, intravesically. The residents know in the past I've done a transvest, cystoscopically, but I don't think I'm really moving away from that. Sarush has really taught me to say, you don't need to do this, Dr. Bandyk. And so I think I've gone away from that, and we're just taking the ureters out, robotically, laparoscopically. I agree with using mitomycin and gentamicin intravesical chemotherapy after a radical nephroureterectomy, because you can do a bladder closure, I think. In that setting, and then if you did a psoas hitch, you just have a bigger opening in the bladder. And I'm resistant to putting mitomycin, something that toxic, in after that procedure. But this is should be performed. Excuse me. And as I stated earlier, lymph node dissection should be performed with a nephroureterectomy. I'm just looking at my time. Good, we're in the right spot. So any questions regarding that's really like the core curriculum, just your basics of upper tract UC. Any questions from anyone? If not, we're going to keep rolling. This is it was a good find, I thought. It was the incidence and survival rates of contemporary patients with invasive upper tract urothelial cancer. And the last time this was done, it was done through MD Anderson. They looked at and so now this group took upon themselves to look at it again. I think it really has interesting information. It describes the contemporary upper tract UC incidence and mortality rates in the United States. And what they did, it was a SEER database analysis of 13,000 patients from 04 to 2016. 70% were non-metastatic, treated with radical nephroureterectomy, 9% were metastatic. And so in all these interesting diagrams, and so this is now, all these are diagrams looking at age-adjusted incidence rates in upper tract UC. And so this is incidence rates by primary site. And overall, you'll see that up to this upper line here, see you go by time, and then on the y-axis, it's the rate per person years. So low incidence, higher incidence. So overall, upper tract urothelial has actually decreased over time, which is good. But the renal pelvis has a higher incidence than the ureter, and they really have stayed stable. So everybody understand these graphs? The incidence rates according to the US regions, they looked at the Midwest, Northeast, South, and West, and there was a decrease within the Midwest and West, and stable in the Northeast and the South. I don't know if that's telling of anything. Incidence rates by T&M stage. The highest rate is in see this red line, T3-4. So the highest is in the T3-4. There was a decrease in the T1 over time, but T3 and 4 really stayed stable in this red line, but you can see how the purple line has gone down. All right. And there was an increase in T1, T4. So over time, so it's still suggesting that the higher stage, the T3, T4 is a problem that needs to be dealt with. The highest rates by tumor grade. You can see that.
Mark,
yes,
would it be possible to go back to the previous slide?
Sure.
Thank you, Mark. Mark, would you have a couple of minutes for me to see what the residents think of this? How are you doing for time, Mark?
Oh, I don't have a case at 8:30. I'm not going to be late to the OR. I can.
Okay, no, we still want to finish at 8:15. So let me just take a couple of minutes and to interpret this slide with the residents. Could one of the residents take this, please? How would you interpret this data, guys? It's saying that over a period of time, and this is from 2004 to 2018 here, there's an increase in T1 to T4 disease. It's an overall increase. The T3 and T4 seems to be stable, and the decrease in T1 to T2. What does this tell us about the biology of the disease?
People are living longer with it?
Yes, that's one thing. Anything else?
So I think we need to look at this graph very closely, Dr. Balaji.
Yes, Bashar.
What this graph is telling us is that the metastatic disease is increasing. That's what it's telling us.
Yes.
It has nothing to do with the T stage. It's the M stage that's increasing.
Yes. So that's excellent, Bashar. So that's exactly what I drive at. You see, as we understand the biology of cancer and the genomics and so on, we're really looking at two different things. You know, some diseases tend to be born aggressive, and then some are not. While we may be able to target some of the lower grade disease, such as, it's very similar to prostate cancer and kidney cancer and so on, by early detection and so on and so forth, the aggressive disease do not give us a chance to react quickly enough. And then even if we do, I'm not sure whether we can alter the course as much. And you will see this pattern again and again, that there isn't a good correlation between early diagnosis or staging, diagnosing these tumors earlier and low grade does not necessarily influence the incidence of high grade or aggressive disease, which again tells us these are probably born differently. And that's something we just need to be aware when we look at a lot of these epidemiological data. Great job, guys. Thank you. Okay, over to you, Mark.
Well, thank you for making that point, because that's really what is the essence of, that's why I like this data here, because it's really pointing for the need of systemic therapy, neoadjuvant, adjuvant therapy. Thank you. The incidence rates by grade, the highest is high grade, and there's a decrease in low grade, but there's no change in the high grade stage again. So in conclusion, that high grade UTC has incidence rates are the highest. The high grade has a stable incidence, but the T3, T4 have the highest rates, incidence rates. T3, 4, as we pointed out, has stable incidence. So conclusion, high grade advanced stage T3, 4, we need to focus our therapeutic management and on these improvements. And as we just stated, it's because of the ability to have metastatic disease. In the same study they did, now we're looking at cancer-specific mortality using Kaplan-Meier plots, looking at TNM stage, and you see the TNM stage at 5 years after a radical nephroureterectomy. So this is still with non-metastatic M0 patients treated with a radical nephroureterectomy. And you can see that the lowest survival is in the T4 disease. And that's significant. So you see 58% 5-year cancer-specific mortality. By grade, 5-year cancer-specific mortality was highest in high grade. Unknowns are likely, no, this is from the SEER database, so this is likely high grades also, but 30%.
Mark, would it be possible to go back to the previous slide looking at the stage, Mark, please?
Yes.
Yeah, so just to draw this, and I think we briefly discussed this maybe at the last meeting or maybe at the journal club. Just want to drive home this point. The way I understand oncology today is stage is the consequence and grade is the cause, okay? It's not that simple, but that's a good way to remember it. If you can look at it, a stage T3 disease here has a cause-specific mortality of 35%, which is exactly the same as a high-grade disease. Mark, if you want to move to the next slide, please. Yes, it's about the same 1/3 mortality. So just remember this, guys. That's why when you and the stage, you know, before we operate on that, it's usually clinical. And then, of course, when you have pathology, it may change. But grade is something that we will know prior to operating. So when you have a high-grade tumor, just be careful about conservative options. I think that's something to consider because a high grade is more likely to have a higher stage. It's more likely to recur, not only distally, but also local regionally. So conservative management of high-grade tumors, I'm not saying we should not do it. Just be careful about making the choice. Unless you really, really need to preserve that kidney, it's a solitary kidney or something, it's imperative, that's different. Otherwise, I would be very careful managing high-grade tumors because these are pretty aggressive tumors. Okay, thank you, Mike.
That's right. It's the high grade is contributing to that higher stage. So there's no difference in cancer-specific mortality from this study between the renal pelvis and the ureter. Female status is similar. Conclusions, the stage and grade are important independent predictors of cancer-specific survival. And so that's, you know, well, that point was just made, thank you. Very significant increase in cancer-specific survival in a high grade upper tract UC and then the T3, T4's disease. So again, focus our improved therapeutic management on this group of high grade T3, T4. They looked at chemotherapy administration. This is now with upper tract UC and metastatic cancer patients according to chemotherapy. So it just shows you the benefits of chemotherapy with or without. And you can see that there's a significant improvement in survival with chemotherapy than with not. Surgical treatment there's a improved survival in patients with radical nephroureterectomy. The others, again, this is SEER database. I would assume this was maybe with nephrectomies, but maybe not properly done because that survival is less.
Sorry, that the chemo was neoadjuvant?
It's, this is just, again, this is SEER information not known.
Gotcha, okay.
Primary site, the ureter has a little better survival than the pelvis, renal pelvis. Overall mortality 62% versus 53%. But you can see what a bad disease this is in the renal pelvis here, metastatic disease, with a median survival of only 8 months. Sex, there is no difference. So in conclusion with this, I thought very interesting paper. Overall incidence of UC has decreased, but the overall survival is really dismal in metastatic upper tract UC with a median 9 months. The incidence of metastatic disease increased over the study. As pointed out, majority of non-metastatic UC was T1, but the T3s were approximately 30%. So metastatic upper tract UC both benefited from the use of chemotherapy and radical nephroureterectomy with overall reduced mortality. But primary ureteral had improved survival. All right, so I'm going to keep rolling here. We have another 15 minutes. So with that information in mind, and thank you for making those points. Adjuvant, we have to think about adjuvant therapy, chemotherapy, neoadjuvant and adjuvant therapy. So we're going to switch gears and now discuss that. Neoadjuvant chemotherapy is presumed to play an important role in invasive upper tract UC based on really muscle invasive bladder cancer, where we really have level 1 evidence of the benefit of neoadjuvant chemotherapy in bladder cancer. But majority of the patients in this disease are renally impaired and are ineligible for cisplatin therapy after surgery. And so the pre-surgical therapy capitalizes on the patient's maximum renal function for optimal modality therapy. So we'll make this point later that we have something that's going to help us in the future. Since staging of upper tract is difficult, concerns exist about what's the potential for overtreatment. We just don't know who we're treating, and are we, whether this treatment is going to be beneficial or not. Cisplatin-based, we're talking about cisplatin-based chemotherapy with gemcitabine and cisplatin or MVAC, but maybe the opportunities are in place for using immunotherapy as neoadjuvant therapy in patients with upper tract, and it's currently being evaluated. I wanted to add these 2 studies in, but just I know it's going to roll over, have too much, but this will be something to talk about because there's 2 active phase 2 checkpoint inhibitor immunotherapy trials in the works now. One in China, one in Europe. So this is, I thought, was this is actually demonstrated the benefits of platinum-based neoadjuvant chemotherapy improves oncologic outcomes in locally advanced cancers. And they investigated the efficacy and safety of platinum-based neoadjuvant therapy in locally advanced urothelial cancer. It was a retrospective single study, but it was a good number of patients. That's the reason I thought this was interesting to present. And the indications for neoadjuvant therapy were T3, 4, with and without nodes, higher risk. So that I chose this study because of that previous work to look at this. Though it was retrospective, they used a technique where they took 51 and they pair matched the patients. between the two groups to match them for, so it was more of a randomized study than with neoadjuvant chemotherapy and control groups. And they treated them with 2 to 4 cycles of gemcitabine cyst and gemcitabine carbo. So this is the flow sheet for doing this. They all underwent radical nephrectomies for T3 disease with neoadjuvant, without neoadjuvant. But see, then they matched this by age, sex, ECOG status, tumor stage, and location. The median response rate for neoadjuvant chemotherapy was 28%. There is pathologic downstaging of the primary significantly higher in the neoadjuvant group rather than the control. The neoadjuvant chemotherapy group had, with locally advanced, you see it prolonged the neoadjuvant therapy, but prolonged the progression-free survival, the cancer-specific survival, and the overall survival. And that's what these graphs show, that there is downstaging with the neoadjuvant therapy by lymphovascular invasion status. You can see that in this progression-free survival, that the neoadjuvant group had improved survival over time out to 10 years. Cancer-specific survival was also improved with neoadjuvant chemotherapy versus the control group in these advanced UTC patients. Overall survival was also improved. Regarding node status, see if node negative, there was really no significant changes with neoadjuvant therapy versus the control. But you place node positive disease patients with these advanced patients, the T3 patients, you can see the benefit of neoadjuvant therapy with both progression-free survival with node positive patients and cancer-specific survival with node positive patients. So in conclusion, in this study, there is the neoadjuvant chemotherapy for locally advanced upper tract was feasible for oncologic outcomes and toxicity. The patients who benefited significant was lymph node involvement. So these would be your potential candidates to consider. The impact of neoadjuvant chemotherapy was significant for cancer-specific survival, but overall survival, not for overall survival. So it's thought that maybe there was the follow-up in the neoadjuvant therapy group did not pick up the overall survival. So there is a survival benefit neoadjuvant therapy in a muscle invasive bladder. Oh, there's a benefit to this, but see, this is a retrospective series, and so this has to be. I'm just going to go to the next slide. Here we go. Home stretch, folks. The last paper I think is very interesting too. This was just published in 2021, and it was a meta-analysis looking at neoadjuvant and adjuvant chemotherapy for upper tract urothelial. And so it was a really 2020 perspective of this. And this is an update on, I looked at systematic reviews, meta-analysis. In this study, there were, so there, both level 1 and level 2 evidence, because there were 2 prospective randomized trials involved with this. There was 4 phase 2 trials of neoadjuvant immunotherapy and 3 of adjuvant immunotherapy. This is their flow diagram, which we can't see that well, but there was the studies evaluating neoadjuvant chemotherapy was 16, and the studies evaluating adjuvant chemotherapy was 29. Okay, so the efficacy of neoadjuvant chemotherapy in upper tract disease. This is looking at a cancer-specific survival, and you see that it's favoring neoadjuvant chemotherapy in this meta-analysis. Regarding overall survival, you see it's favoring neoadjuvant chemotherapy versus control. In conclusion with this, with neoadjuvant chemotherapy is really favors, this study favored the neoadjuvant chemotherapy. There was 11% complete pathologic response rate, 43% partial response rate, and overall survival with the hazard ratio and of 0.4 and 0.3 is significant. So this shows the benefits of therapy in these patients. Neoadjuvant chemotherapy confers a favorable pathologic response and downstaging of the tumor. Because of the retrospective studies, I think they're saying this is level 2 evidence for overall survival and cancer-specific survival, comparing the neoadjuvant therapy with radical nephroureterectomy alone. Now we're looking at the efficacy of adjuvant chemotherapy and overall survival in this group, in this meta-analysis. Here, the study demonstrated overall survival really favored adjuvant chemotherapy versus the controls. In disease-free survival, the adjuvant chemotherapy was favored over the controls. And cancer-specific survival, the adjuvant chemotherapy was favored over the controls. The results favor adjuvant chemotherapy.
Just a quick question to our residents who do and fellows who do a lot of this meta-analysis. Guys, there seems to be a significant difference in the hazard ratio between neoadjuvant chemotherapy and adjuvant chemotherapy for upper tract tumors. Does that mean we should start with neoadjuvant in these patients? Because adjuvant does not seem to be as effective. You know, if you look at this meta-analysis here, it almost touches the no difference line. Whereas if you look at the previous couple of slides, the hazard ratio is 0.3 and so on. So how do we interpret this, guys? Should